For those who expected a different center to present, that is correct. They had a short-term problem and had to bow out. So I do apologize for that, but I think we have a great program instead, and we're always happy to kind of fill in, and we want to provide meaningful for the educational advantages. And today's topic is one of the probably most relevant topics in terms of research that I know of. The main discussion today is the so-called SPORT trials, the Spine Patient Outcomes Research Trial. And we thought that over a decade later, we'd look at it from a big picture, long-term lens again, because it tried to do something that is very hard to do. It tried to apply the principles of the most meaningful, highest ranked research, that is prospectively randomized clinical trials, to minimize bias, and pit in 3 common spine conditions: disc herniations, stenosis, and spondylolisthesis in 3 separate sub-trials, surgical and non-surgical care with one another. And there are over 2,500 patients assembled in this from 13 major sites, and it was led at Dartmouth, and it was, again, formally registered, formally federally funded. I forgot what the final tally was, and it may still be accumulating from the long-term follow-up studies, but it was substantially funded through taxpayer monies to answer the main question of, is surgery or non-surgical care better, safer, more effective than the other? So it was a very substantial body of effort led by our Dartmouth colleagues and Dr. Jim Weinstein and his faculty there, under input of many very noteworthy centers. So this is over a decade ago. It started around 2000. The first publications came out around 2007. And now we have a more long-term perspective. Some long-term follow-up studies were published. And through this lens of longevity, we want to look at what do we actually know? What have we gathered from these surgeries? We have 4 speakers today, and they're chosen with thought. Our lead-off speaker is Daniel Norvell. He's a PhD epidemiologist who is the co-president of Spectrum, and he is going to provide a very substantial kind of a methodologist perspective on the unanticipated and methodological challenges of the study. Because there were some insights, and I don't want to steal his thunder, that really made interpretation of these studies very difficult. As simple as the design sounded, it really was very problematic, and to the present date remains difficult to understand what we're actually looking at. So we thought he'd provide his input and some operational definitions to empower us all from a long-term perspective to look at this. And we recently actually talked about the SPORT trial in one of our afternoon research sessions as being such a landmark study. 3 of our fellows kind of were kind enough to pick up the thoughts that we had accumulated, and will in separate sequence discuss the findings of the 3 subsets of these studies. Dr. Maurizio Avila will talk about spinal stenosis first in a brief about 10-minute summary. So, sorry for the interruption. There was a report of some Zoom difficulties. So our first speaker will be Dr. Dan Norvell, PhD. He's going to provide an epidemiologic perspective of the anticipated and unanticipated findings. Dr. Maurizio Avila will go second, and he'll talk about spinal stenosis surgery. Dr. Jonathan Plummer will talk about the degenerative spondylolisthesis trial. And finally, the first of these studies will be ended up with Dr. James Hicks, who is right now at one of our other hospitals trying to see a consult, is going to finish up, hopefully I'll make it in time, on the disc herniations. So Dr. Norvell, Dan, are you live?
I'm live. Can you hear me?
Yes, loud and clear, and we see your slide very nicely, and there's some ball sport replicas in the front slide. So thank you for joining us on short notice. Just for the audience, yesterday, if you want to dial in, his partner and co-president of Spectrum Research, Dr. Joe DeTore, retired, and he gave a great retirement perspective from an epidemiologist's view of spine research over the last 3 decades. And you can just go into the SSF TV STEDS talk, Spine technology, education, discovery channels to see this wonderful lecture in terms of a unbiased perspective on where we are in spine research. So dial that in. But Dr. Nova was so kind to kind of give us a big picture perspective on what kind of insights we gained from a statistician's viewpoint. So thanks for joining us, Dan. Look forward to your insights.
Thank you, Jens. Thanks for the invitation to be part of this. And as Jens said, I'm an epidemiologist, and I'm going to give the bigger picture view of some of the methodological concepts that we have to consider as we're evaluating these studies. I won't get specifically into these studies. We'll have more opportunity for that as we move through this. So as we get into this, the first question we really need to ask is, how can we trust the results of the study? And maybe more importantly, can I apply the results to my clinical care? Well, the foundation for that is the level of evidence, or the evidence pyramid. Many of you have seen this, gone over it multiple times, but I think it's worth revisiting. And that is the top of the food chain for evidence is the meta-analysis, followed by a randomized trial, cohort studies, and so on down the line. Now, this system is largely driven by study design. It plays a major part in it. The problem, as we know, as we'll see in sport, you may have a great study design, but things begin to change, sometimes even fall apart, and biases begin to come in. So it starts here, but we need to consider the other issues. Having said that, I think in any type of talk like this, we need to really recognize the importance of randomization. What does randomization do? It equally distributes the unknown and known factors between groups. And by doing so, it has the best potential for eliminating bias. So why is bias important? Why should we consider it? Well, we want to hit the bullseye, right? We want to know if there's a treatment effect, if it's real. The more bias we have, the less likely we're going to hit that bullseye. And it continues to be the case. The level of evidence is still the best measure of the study of bias in judging an article. So we have to start there. So what are the different forms of bias? I'm going to list a few here that are really relevant to today's conversation. The first is in the selection of patients. Second is in the measurement of outcomes. Then in loss to follow-up. That's a big one in the sport trial, especially as we get further on in the follow-up. And then finally, in the presence of confounding. When there are factors that are unequally distributed that may affect the outcome, we definitely have to take that into account when we look at these observational studies in particular. So quickly, how does confounding bias influence results? Let's look at a hypothetical example of an observational study. 400 patients with an index vertebral fracture, 200 receive vertebroplasty, 200 do not. And we observe them for 2 years, and there are 45 subsequent fractures over that time period. Well, if we look at the two groups compared, again, hypothetical data, we see that the risk in the vertebroplasty group is 15%, conservative care 7.5%. So would we trust these data? Does this mean that the risk is 2 times for another fracture if one were to undergo vertebroplasty? In the presence of an observational study, we need to ask some questions. And the most important one is, how are these factors distributed? Are there factors that may affect the outcome? And the easiest way to do that is just to look at a table 1 or to look at the distribution of factors between the two groups. This is just a quick example. So when we look at age, we see that they're similar. Weight, similar. Smoking status, a bit of an exaggeration, but here we see a much greater proportion of smokers in the vertebroplasty group versus conservative care. So again, is there really 2 times the risk, or is there a way we can look at this differently? Well, we can. We can stratify the results by smokers and non-smokers. When we do that, we see that the risks are much higher in the smoking group, but they're the same essentially between the two groups that we're comparing. Non-smoking, lower risk overall, but again, similar. So this is a quintessential example of confounding. And when we adjust for it through a simple stratified analysis, we see that there really is no difference between the two groups. So how do we minimize confounding bias? Well, again, random allocation is the most important and first and foremost way to do that. But we understand in surgical research and many other areas of research that it's a difficult thing to do, which we'll talk about today. But we start with that and we move our way down. I want to show what randomization really is intended to do. which didn't actually happen in the SPORT trial. If we took a hypothetical population of 170 patients, and let's assume that 100 of them had a composite of factors that gave them a good prognosis. And the other group, 70 patients, had a composite of factors that gave them a poor prognosis. We randomize them to treatment A and B, and if randomization works, we will get an equal distribution of those with a good and a poor prognosis in both groups. And if those who are assigned to treatment A get that treatment, and those assigned to B get that treatment, we can assume that the treatment effect we observe is real, and it's not confounded by other factors. That's the ideal scenario. That's not what we saw in the SPORT trial, right? We'll get into some of the details with the studies, but I think there was nearly 40 to 50% crossover between the two groups. So let's take a look at what happens with crossover and what our options are for analysis. So again, random allocation, let's say to a treatment group and a control group. Some of the patients in the treatment group cross over to control. Some in the control cross over to treatment. And we have three options for analysis. The first is intention to treat. Many of you are familiar with that, and it's exactly what it means. What were they intended to be treated by? That analysis is simple. We leave everybody in the group they were randomized to, and we compare those two groups regardless of the treatment they got. The next is per protocol. And the SPORT trials really didn't do this, but it is important to note that it is an option. And essentially what you do in a per protocol analysis is you throw out all the crossovers. So this ends up being missing data. And you just analyze those in the treatment group that were randomized to that group and the control group that were randomized to that group. And then finally, in the as-treated analysis, which we've seen in the SPORT trials, essentially an observational study. You analyze patients in the group in which they were ultimately treated. And so what are the strengths and the limitations of each of these methods? And I think this is kind of a key slide to consider. So intent to treat at first blush appears counterintuitive. Why would we do that? Why would we analyze people in a group that they didn't get that treatment? Well, first and foremost, if you remember that slide I showed with the bar graphs, intent to treat in the randomization at least preserves the prognostic balance between the two groups. So therefore, it will minimize any bias as a result of those factors, especially unknown factors that we can't control for, which may be patient or surgeon factors. So intent to treat is the gold standard really for the analysis. Per protocol, it's going to answer the question as to whether the treatment works in those that received it. Because we throw several out where we don't know their outcomes, we can end up with a type 1 error or actually finding a treatment effect when it's really not there. So there are limitations to that. And then finally, the as-treated analysis. As I mentioned earlier, this turns it into an observational study, which leads to a greater potential for confounding bias. And the most difficult thing to account for are those unknown factors. And especially in the SPORT trial, because of such a large amount of crossover, that's difficult to account for. We may be able to understand why they're crossing over, but how do we control for that? And that's something that we need to be talking about even today as we're looking at the data. Those unknown factors can truly have an effect on the treatment effect. So let me give another hypothetical example of how these different analysis techniques could give us a different answer. Let's assume in these patients with an index vertebral fracture that there's really no difference in the treatment, whether they receive percutaneous vertebroplasty or watchful waiting, conservative care approach. No difference. Let's just assume that's the truth. And 100 of the 200 patients are randomized to vertebroplasty, another 100 to watchful waiting. And we observe them over a 1-year period. And our outcome of interest is any new fractures that occur. Well, as we know, typically, and it happened in the SPORT trial, is that there's often a delay between randomization and when the patient actually receives the treatment. So let's say in this case, that delay is about 3 or 4 weeks. And there's actually 20 new fractures that occur in the vertebroplasty group even before they get the procedure. And again, because we're assuming these groups are equal, the treatments are equal, let's say that another 20 occur in the conservative arm during that same period. When we look at the rest of the year, 20 fractures occur in both groups. So 40 in group A, 40 in group B. How can we analyze these data? Well, let's go to the intent to treat. Simple, right? 40 out of 100, 40% risk, 40 out of 100, 40% risk in the watchful waiting. Essentially no difference between the groups. And if that were the truth, we'd get the right answer. Intent to treat would give us the right answer. For per protocol, what we would do is we'd throw out these 20 fractures. Okay, so that would reduce the denominator in the vertebroplasty group. Now we have a risk of 25%. Watchful waiting remains the same, risk of 40%. We now see a protective effect in the vertebroplasty group. It's more effective when we look at it from a per protocol standpoint. And then lastly, what about an as treated approach? Here, we actually would move these 20 fractures down to this arm, right? And when we do that, we increase the numerator. We also increase the denominator. So now we're looking at 60 over 120, or a 50% risk in the watchful waiting group if we use an as treated analysis. So double the risk in watchful waiting. So you can see how, even though this is hypothetical and it was different in the sport trial, it gives you an idea of what happens when we look at these in different ways. We can get a different answer. And so, I didn't have a lot of time because we want to get into the studies, but I did want to talk about some issues that we ought to consider as we think about the effects of crossover, and in particular with the sport trials. So first off, as many of us know, surgical RCTs are very difficult to do, and crossover is a huge issue. And a large part for that is the complex nature of surgery. And that's something that we can't get around. And that's why I am a big proponent of observational research. And I think it ought to be continued to do, because we have these issues. And then we've also got this lapse between randomization and intervention where these crossovers begin to happen. The second thing, and I showed it in that prior slide, is that crossover can either dilute or even distort a potential treatment effect. And so when we look at these studies, we need to think about what kind of patients are crossing over. Is it an equal distribution of factors that might affect the outcome, or is it unequal? Need to pay attention to loss to follow, especially in long-term studies. And again, with surgery, we really want to know. It's not just the 1 and 2 year outcome, right? We want to know 5 years, 10 years, even 15 on how effective these treatments are. And so unfortunately, in any studies, doesn't matter what they are, loss to follow-up is an issue. And so the question is are sicker patients, or perhaps patients that are getting worse, disproportionately falling out in one group versus another? It's another thing we need to consider when we look at the comparative outcomes at the end. And then finally, how do we address these issues? Well, I think first off, we just need to identify them as limitations. Every study has limitations. Once we've done that, then can we look a little bit closer at the data and find out perhaps how these crossovers could affect the potential comparison, both say in an intention to treat analysis as well as in an as treated analysis. Also want to consider the effect of the follow-up loss, which could lead to bias. And then finally, there are statistical techniques to control for confounding once a study becomes an observational study. But again, the limitations there is there are unknown factors we often can't control for. So those are things to be thinking about as we go through each of these studies and discuss the validity of the results. Okay, that's my time, Jens.
That was awesome. Thank you, Dan. One question, I'll just pick on Dr. Lieberman. So our friend, Dr. Michael Longley, correctly identified how the randomization of the study was truly the Achilles heel of the whole sport trial. And the sport trial was the mother of all, going to be the mother of all spine surgical randomization trials, prospective. We've just heard the outline from Dan, controlled clinical trial. Dr. Longley identified that the randomization was a problem because it was too slow. Many sites persuaded patients who are not interested in being randomized to enroll and then changed the treatment arm. So the crossovers were just the unanticipated major problem. And as Dan pointed out, it's led to all sorts of complex and still debatable issues in terms of how to interpret what actually was found. So is this mother of all surgical spine trials the end of all prospectively clinical randomized trials? Izzy, how do you see this methodological challenge that occurred from the perspective of like 15 years later?
Great question, Jens, as always. You know how to pull out the issues. You have to go back to when the sport trial was started. And this is well over 20 years ago. This is probably 25 years ago, I think this was initiated. And what we knew then, we don't know now. So I would not criticize the work of what they did in the past on the basis of what they know because of what we know today. Now, do you throw out the sport results? No. Let's use this as a foundation to keep building. And on top of that, today we have much better statistical methods, and I think we have much better technology with collecting information so we can get good information in place. And on top of that, we've got better machine learning, predictive analytics that's going to help us really define what's going on. Now, this all depends on, as was pointed out, the design of the study. And today we can design studies better on the basis of what we learned from the sport trial. So I wouldn't throw anything out. I think it's important information. Has it changed our practice? Yes, to a certain extent, but let's learn from it and move on from there.
So thank you. That's a great perspective. Dr. Ziegler, Dr. Geyer, I'll ask either of you first. You and Scott, the three of you were kind of senior authors of landmark prospective surgical trials. How do you see from those successfully conducted, incredibly large bodies of work involving artificial disc replacements, the randomization challenges that you saw in the surgical versus non-surgical trial? Is this even a legitimate construct anymore? What is your perspective in terms of what the indirect learning effects were of the sport trials?
Yeah, I think we learned what cannot be enrolled. So I think what we learned is how to design a trial that has a better chance of being successful. So that's, trying to get someone right now to randomize two level fusions when they can get a 2-level cervical artificial disc on their own insurance, or in the coming year, even a 2-level lumbar disc replacement is a thrash. It's just not going to happen. You're not going to be able to get people to enroll if their randomization is something that they don't want and they don't have to take. So I think it's helped us design studies in a better way. We've also learned how expensive these studies are, and the paradigm of the government paying for studies has gone away because of the cost. And it shifted to industry-sponsored studies with governmental regulation. And at first, everyone was skeptical about that, but it's actually worked out quite well. There are several layers of monitoring and regulatory oversight. And, the penalties are so harsh for cheating that nobody cheats. So I think that it is the best of both worlds. I think you get the sponsor who's got a lot at stake financially to risk the money for the study, and yet the government gets its own oversight in a study that's hopefully designed to enroll. So that was the lesson that I learned from participation in these huge trials.
Great.
Yeah,
so,
just to echo what Jack said, I think that the TDR studies were very, very specific, and there was less chance. Certainly, there were no crossovers and intent to treat. Basically, the patients enrolled. There were still certain biases, and I think Jack alluded to that, but they were still really, really good scientific studies, and that we tried to study simple choices. Either they got the artificial disc or they got a fusion, but even people complained, for example, the Protis was randomized to a 360 and the Charité to an A-lift. And are they really the same? But the subsequent studies now, with the disc-to-disc studies, they're relatively simple. And we learned those lessons, I think, from sport. And as Izzy said, you can't criticize the sport trial. It's just, that's where we were back then. And now we are, we learned from all these previous studies and subsequent studies.
And let me hear from the other, the third of you disc trial guys. Scott, did you have a hard time enrolling patients in your disc trials? I mean, the length of enrollment and kind of pushing patients towards enrollment was one of the main problems, as pointed out by Dr. Longley. So did you have a problem enrolling patients? Was there protracted enrollment, kind of a time period? If you can't answer, Rick, maybe you can answer that because you were in on those initial
Sure.
trials.
No, not actually, Jens, because I think people were so excited about getting the artificial disc. It was relatively easy. Unfortunately, if they didn't get the artificial disc, they were disappointed. So that was sort of the internal bias of it, because patients wanted to get the artificial disc. But then the subsequent studies that were disc to disc, it was a lot easier. And patients loved it because they didn't have to pay anything out of pocket for it, because the industry sponsors would pay for the artificial discs themselves on all sides. So it was relatively easy. And even to this day, because now the FDA requires follow-up for 7 years and 10 years now, patients come back. Now they have incentives from the industries because they want the data, and which is fine.
This is great. You said the bingo word, and then let's start with Maurizio, patient motivation. So this is a key word in this whole thing. So Maurizio, take us into the stenosis. Thank you for your comments, guys.
Thank you, Chapman. So I'll start with the first of the 3 10-year follow-up trials. So this was published in 2019 in Spine, systematic review of the 10-year mark of the sport trial for spinal stenosis. Briefly, as we know, spinal stenosis can be a quite disabling condition and is one of the most common causes of spinal surgery in patients above 65 years of age. Before sport trial, as we're already discussing, we had small case series, small sample size. So again, it's not usual to have a randomized control trial in any surgical specialty. I think in spine surgery, there's a handful. So I think that's why these trials were so important for good or bad in our practices. For this particular paper, so they basically did a Prisma with using the Prisma guidelines to do a systematic review. They use different databases, PubMed, Medline, and Embase, only English language studies. And as you can see from that figure, basically the one that I'm going to be focusing about is the one with the spinal stenosis. So they had 15 articles. And I put there as a reminder, the primary outcomes of the sport trial were SF36, the short form of the health survey, and the ODI. Those were the primary outcomes. And in this systematic review, they divided the results in the primary studies with the primary outcomes and what they found 10 years later on subgroup analysis of the trials. So going straight into the results, again, this is the primary studies. So I'm just going to highlight as treated. Dr. Norville already talked about this issue, so I'm going to focus on the as treated. As you can see from the primary study that was published in 2008, the as treated as in 3 months, 6 months, and a year, surgery was superior to non-op management for spinal stenosis. In 2010, that's the 4-year mark of the follow-up. For the patients who were analyzed as treated, surgery remained more beneficial than non-op management. And then, sorry, there was an update here, okay. But then at 8 years, as you can see here, the as treated group, now there was no difference. Even in the analysis intention to treat, there was no difference at 8 years. So basically from 3 months up to 4 years, surgery was superior to non-op management. Again, SF36 and ODI. But at the 8-year mark, there was no difference between surgery and non-op management. Now, the second part of this study is the subgroup of secondary analysis. I just highlighted from the article some key areas for epidural steroid. Patients who receive epidural injections had significantly decreased improvement at 4 years, which was interesting. The patients who had surgery were younger patients. We were talking already about bias earlier, and had more lateral recess stenosis compared to pure central stenosis when they reviewed the images. Smoking, I think this is a very important one. Patients who smoke had worse outcome, and then one of these secondary studies, when they removed the patients who smoked, surgery was much better at 4 years compared to non-op. Obesity, I think since 2008, there's many studies in different parts of the procedures that we do that we know that obese patients have more risk of infection. And I think importantly here, also has less improvement from their baseline in either treatment. The last two here, interesting enough, from the pure radiology perspective. So there was good agreement between the centers and the radiologist for central stenosis, but there was a very marked variability assessing the subarticular zone stenosis or lateral recess stenosis, which I think is interesting as well. Again, another potential source of bias. Reoperations, of course, if you have a surgery, there's a risk of reoperations. Interesting, the main risk factors there is people who multiple level stenosis, those who have greater leg pain pre-op, the use of antidepressants, and no neurogenic claudication. Those patients were at high risk of reoperation in this follow-up subgroup analysis. So this is the conclusion for the systematic review 10 years later. So as I mentioned, surgical intervention showed great improvement from about 6 weeks mark through the 4 years, but then there was no difference between surgical and non-op management, basically from 4 years up to the 8 years. So then, of course, the questions to answer is this the natural history? Does your decompression last only 4 years, and then there's going to be, again, a new compression at that time point? And the follow-up question is, how long is good enough? Are we expecting if we do a decompression that is going to last forever? Or is it expected that we can tell patients, this will be good enough for about 4 years, and then you need a reoperation? And then my last two slides, Dr. Chapman asked us to also mention just briefly the original trial. So this was, again, published in the New England Journal of Medicine 2008. As I mentioned, not every day you get a New England Journal of Medicine article for spine. I think the last that come to mind is Dr. Gorwell's sleep study a couple of years ago. So again, it was 13 centers. And as I mentioned, for spinal stenosis, surgery was better than non-op management, again, for SF36 and ODI. And as Dr. Norville mentioned, this is one of the figures that you can see the patients that got randomized, and then the more boxes you see, and I did this on purpose, it's hard to see, but all the changes, all the crossovers, and then the big warning sign is from the non-op groups, how many underwent surgery. So I think that just try to brings home the point of the amount of crossover and the amount of patients who initially were either randomized or themselves selected to not have surgery, end up having surgery. And I think one of the boxes as high as 42% of those patients end up having surgery.
And picking on that, Maurizio, that's a very nice summary. I liked how you did that. How many of the non-surgical patients had to convert to surgery due to emergent neurologic problems? How many were kind of elective? Did they get that sorted out?
But as far as I can tell, no, not that I remember for emergency. One big thing of the original study is if the patient selected to not have surgery, they don't even go out randomization. They were just already in an observational cohort. And as you can see from that one, they also at some point had the opportunity to undergo surgery.
Great. So I'm going to ask Izzy first, and we have to make it very quick in the answers because we have to keep going. Izzy, you mentioned that nowadays we have better statistical techniques, but also outcomes parameters. The problem here, as Maurizio insinuated right off the bat, was SF36 and ODIs. How meritorious are they in this long-term perspective in terms of actually capturing the effects of spine surgery or non-surgical care? Izzy, are you live? Do we have a freeze? Okay, Rick, are you live? I'm worried about the internet connection. I don't see your face. Okay, Dan, we've published a book on, oh yeah, here's Jack.
Yeah.
Okay, Jack, how in the long-term perspective, how valid are these two technologies, these techniques to actually measure how well spine patients are doing?
Yeah, I mean, there's had such historical importance, and if you want to compare outcomes to prior studies, you know, you need to have equivalent instruments. So we've debated that. Are they still relevant or not? And likely we could do better if we were designing newer instruments to use. But then you run into the difficulty of trying to use the classic studies as a comparator. So, you know, maybe we'll get a blended or a newer additional way to do it, but we're constantly trying to condense our case report forms and patient obligations at every visit, not expand them. So it's a difficult problem, but everybody acknowledges that we're probably using clumsy instruments that are not as reflective of today's lifestyle as they could be.
Let me ask you a pointed question. Has the PROMIS score or have some biometrics of functional scores improved upon ODI and SF36? Would you prefer PROMIS, for instance, nowadays over SF36 and ODI or NDI?
You know, it's the same reservations then, Jens. You know, the criticism would always be, well, how does that compare to what you've done in the past? And you have so many thousands of patients now in your database. How are you going to compare your new patients with a different scoring system? So there's reluctance to use a new scoring system when you're spending so much money on a 5-year study. You at least want to stick with something that you know is tried and true.
I see Scott live. Can you introduce your partner next to you, Scott? Can you speak? Scott, can you turn your microphone on rather than goofing around?
He's in Santiago, Chile. I know that. Yeah.
So that's JJ Abitbol next to him, but he can't talk. Scott, can you talk or not? Can you talk, Scott? Otherwise, we'll go to Rick. Rick, can you go live?
Yes, Jens.
So I have a very sensitive question. You're the ultimate politician to answer that. How much does surgeon quality or experience matter? So in your very large landmark PRCTs, did you ever look at surgeons and assess the surgeon technique factor or experience factor? You guys do thousands of arthroplasties, yet you have some surgeons who enroll like 3 or 5 patients. So how does that factor in the surgeon variable?
You know, Jens, unfortunately, I think it does, but we had no way to quantify it. And, you know, without looking at the data, it's hard to say. You know, your intuition is that the more you do, the better you get. And I can only tell you that, you know, the 3 of us at TBI, you know, we certainly do a much better operation today on any of our disc replacements than we did in the beginning. You know, there have been some papers in the past with various surgical procedures. And I think Casey Lee years ago published one back in the 80s about doing spine fusion, but we don't have any data on disc replacement, to be honest with you. I think it does make a difference, but that's just my, you know, my bias.
And that's a great.
Hey, Jens, this is Dan Norvell. I know in the, I think in the arthroplasty literature, it definitely makes a difference. And there's some reference to suggest at least 10 procedures or more. If under that, the outcomes are not as good. And so I do think that needs to be considered if you're in a non-pragmatic sense, but then if you're wanting to do a pragmatic trial, you just go with that. And again, you hope that there's an equal distribution. But there definitely is evidence in other areas of surgery that experience makes a difference. So you can control that if you want, but then that limits the number of people that can participate as far as surgeons.
That's a really important point. Like in the English NHS literature for scoliosis, I'd pick on Izzy there. If you did more than 40 cases of scoliosis in a center in a year, your complication rate was dramatically lower. So this is one of those untold things. Surgeon technique and experience seems to matter, and center process control seems to matter. So let's go on to degenerative spondyes. Dr. Jonathan Plumer from the University of Bochum is here, and he's going to give us an independent perspective in his review of degenerative spondee treatment, surgery, non-surgery, sport trials.
Yeah, good morning. I'm presenting the second systematic review by Olsa et al. On the 10-year mark of the sport trial results on degenerative spondylolisthesis. This review was published in 2020 in the Spine Journal, and I will give you a short overview of the review, and then before we talk about the secondary studies like Mauricio did, I will recap the results of the primary studies. So let's take a short look at the review itself. Included studies were listed in PubMed, Medline, Embase. Same for the review, like Mauricio told us. In English language, all levels of evidence were included, and they included investigations looked at clinical impact of the data, outcomes for special patient subgroups and complication rates using the sport trial data for DS. So the systematic review included only 10 studies on DS using the PRISMA guidelines. So let's look at the primary studies. The two original papers of the sport trial on DS were published by Weinstein 2007 with 2-year follow-up and 2009 with a 4-year follow-up. Like in the other sport trials, the study cohort was divided in a randomized and in an observational cohort. We already heard about this. Patients unwilling to undergo the randomization were placed in the observational cohort. So primary outcomes were the same, like SF36 and ODI scores. Surgical treatment for DS was included posterior decompression laminectomies with or without bilateral fusion, and the used graft material was exclusively iliac crest bone with or without pedicle screw instrumentation. Non-operative care was based on PT, home exercises, and also on anti-inflammatory drugs. So let's look at the actual data. This is for the randomized arm of the study. The results of the primary study were also divided into intention to treat and as treated groups. We already heard this. This slide shows the results for the primary studies for the intention to treat group in this slide, and for the randomized arm, which basically shows no difference for the intention to treat group for surgical versus non-surgical treatment after 2 years and also after 4 years. On the left side. So all in all, there was a high non-adherence to the original assigned treatment groups. We already heard this as well, and a high patient crossover between these groups. When we look at the observational arm, and it was already told this, it was kind of the same like Mauricio told us already. In the S-treated cohort, we can see that the surgery results in a better outcomes compared to non-operative care. And this surgical effect even continued after 2 and after 4 years. So let's look at the secondary data. And this review included, I think, 7 or 8 articles. I will kind of show the results on this, comparing the sport trial data to national data on DS. It was shown that the sport trial data was actually comparable to a national cohort using data of the NSQIP. So generalizing the sport trial data for patient with DS seems to be possible, at least for a cohort in the US. It's the first study. Then subgroup analysis was done by 5 included studies. One study showed that the strongest treatment effect was based on patients' expectation and baseline satisfaction with the symptoms. Further studies showed that patients with leg pain improved the most after surgical treatment when compared to patients with predominant lower back pain. Furthermore, regardless of the initial grade of listhesis or the disc-based, patients after surgical treatment improved more concerning the quality of life results. And the fusion in general resulted in improved clinical outcomes regardless of the used technique. And using iliac crest autograft showed no difference compared to fusion with autograft. So let's look at the complication rate. The complication rate for the secondary study, or for the data as well, was like 22% for reoperation within 8 years. And there was a higher association of reoperation with 2 or 3 moderate or severe stenotic levels with pain localized to the back, to patient without PT treatment, with absence of neurogenic claudication, and with overall greater leg pain scores at baseline. And looking at incidental durotomies, around 10% of all the included patients had incidental durotomies after surgery in the trial cohort, but there was no difference in the incidence of nerve root injuries, mortality, additional surgeries, and quality of life outcomes after 5 years compared to a group without durotomies after surgical treatment. So the review concluded that the sport trial is still a landmark study for the treatment of spinal pathologies and for degenerative spondylolisthesis, and that it is the foundation upon we as surgeons adjust our surgical treatment for DS based on consistent positive treatment effects in the S-treated analysis. To draw my own conclusion, I would say that there are serious limitations to the results because there's, or caused by a lack of adherence to the original treatment plan, which overall might have, end up in a low significance of the data. And the second major downside, I would say, is, in my opinion, that the surgical technique, in this case for effusion, wasn't mentioned. And I mean, this was even the problem in the non-surgical group. So yeah, these are some of the limitations to the study.
So Rod, this is really nicely done. Thank you, Jonathan. Rod, the surgical, can you go back to the, I think the first outcomes graph slide from the Weinstein studies? One of the biggest things that I always stumbled over was, as a surgeon who does front and back or circumferential fusions for degenerative spondies with cages, they couldn't find differences of the outcomes of just in situ fusion versus screws versus cages and screws. How does that affect you? Did you saw these study results, obviously, did that affect you? Did you then go back to doing less invasive, less circumferential fusions?
I mean, I think I probably, I'm a little skeptical about the data, and I do think, going back to your early point, I think, with these studies, you got to look at like things that we have a hard time quantifying, right? So surgeon experience, what are they actually doing? Again, an 80-year-old having surgery versus a 60-year-old is a huge thing. And I think some of that gets lost and again, and Joe Spectrum, Joe Deditori gave a great talk yesterday from Spectrum. And, I think if you really carefully analyze some of this data, you can start finding some serious holes in it. And so, I think for me, these kind of studies, you really have to carefully look and see what it is actually that they're, looking at. And again, in my experience, 60-year-old has a 1-level fusion. They go home the next day, 70, 80-year-old, might stick around the hospital for 4 or 5 days. And long-term, when you follow these patients, and which was done in the study is, what kind of follow-ups being done? How are they, again, pain scores, all these things, how are they collected? All those things make a huge difference.
Sure. Hey, Dan, so this is, again, back to our statistician's perspective. The white circles and triangles have no difference. The as treated observation group was completely different. How in the world can we kind of make sense of that? This is just mind-boggling.
You mean the intent to treat versus
the intent to treat group. So the purely randomized protocol group had no difference. The other group had stark differences that were sustained. I still don't understand it all these years later.
It'd be very difficult to quantify it, but I will say this, the crossover was so large that I don't think we can rely on intent to treat analyses. And I wouldn't say throw them out. Of course, what I talked about is it's the gold standard, but not in this study. That is my sort of generic explanation. I would focus on the as treated, and then we need to think about what are the limitations to it. That's my view, because the intent to treat is really intended to account for maybe a little bit of crossover, nothing like this. So I just don't think we can look at those data and trust them at all.
So let's go on with the last presentation, then we'll have an open forum. I want to shout out to Dr. Maniana from Libya. Thank you for joining us. I know there's a lot going on in your country, and it's particularly meaningful to have you. So good afternoon to you, and thank you for joining us. Last speaker is Dr. Jim Hicks from Alabama, and he's going to talk about the most basic thing, disc herniations, the original trial.
Yes, here we go. So
be closer to the microphone.
Definitely. So first we'll talk about the original. Great, thank you. The original disc herniation paper from Sport, and then we'll move into the 10-year follow-up there. So as discussed before, we've talked about the intention to treat and as treated, but some people will consider it as probably the best version of a random control trial that we can do these days, with patients choosing between the observation and randomization and going into these groups. Participation in this actual trial was after the standard 6 weeks of non-op care. There's high crossover rate, which is one of the weaknesses of the study, which we've already discussed. ITT and as treated. ODI SF36 surveys were used. There were significant improvements in the operative group at time points, with narrowing at the 2-year time point and then with the non-op group. There are certain critiques, including the heterogeneity of disc herniation, which is included in the study. And we'll get into that a little bit later with the weaknesses of the study. But there are also a variety of patient symptoms and severity included, which we've talked about in previous conferences. So moving on to the 10-year paper, which we've all this is the third arm of this 10-year mark. And 29 articles, so I think most articles were on disc herniation in terms of this 10-year follow-up and the systematic review. And inclusion criteria, English-speaking studies involving sport. So this is just a very nice table that helps delineate a little bit of that intention to treat and as treated analysis. And then you can tell at the 4-year mark and even at the 8-year mark as treated, so people that essentially crossed over to the observational cohort, there was a favorable outcome for surgical treatment. And again, whether that's the patient crossing over into within the intention to treat or to the observational, the as treated results are significant. The intention to treat results were not as significant, if at all. So really the discussion in this paper really focused on the results throughout the many different things that they were looking at. So it took a couple quotations here, but patients did not have joint problems, diabetes, those who were married, those who had worsening symptoms at baseline demonstrated greater improvement with surgery. Again, patient selection. And going further into this, so people with sequestered fragments on MRI tend to do better, higher levels of baseline back pain with accompanying radiculopathy, longer duration of symptoms, those who were neither working or disabled at baseline. So again, a little bit of what we already know, and we're beginning to know maybe in the early years of sport. Obese patients did benefit clinically and significantly, but not as much as the thin patients. They had an increased operative time, which was essentially the really only significant a factor for them, apart from not getting as much benefit from their surgical treatment. And patients with upper lumbar disc herniations tended to have persistent symptoms, did better with surgery, although there were a large number of patients with upper lumbar disc herniations that did end up transitioning over to non-op care, even with, so they did have high crossover. Further results and conclusions, 6 months of symptoms or more is a poor prognostic factor, no matter what you do. So that is kind of tried and true. And if you can get to a patient before 6 months and help relieve their symptoms, that's probably the better option. Patients preferring injection were more likely to persist with their non-op treatment. Opioid users had worse outcomes overall and actually preferred surgery. And patients who preferred operative treatment, usually younger, had lower levels of education, higher levels of unemployment and disability. Physical therapy sub-analysis in the non-op group wasn't significant at 1 year, just in terms of if they were actually assigned to formal physical therapy. And patient expectation of improvement was actually most associated with that success of non-op care. So the patient's mentality going in to their care and their education is significant. No difference if you have a durotomy intra-op in terms of these patients' outcomes, and the reoperation rate of 15% at 8 years, and 62% of this was recurrent disc. And again, the weaknesses, failure to address the many morphologies of disc herniation. We know there are several different types of disc herniations in different locations, which I have here on the slide. And then how this affects my practice, fairly generic conclusions here, but recognize that the patient with severe symptoms with confounding factors that may portend a bad outcome, have great education with the patient, a surgical decision, and treat along the appropriate time frame is still very important. But I think we can probably discuss these weaknesses quite a bit.
Nice summary. Thank you, Jimmy. So aside from the fact that we want patients to get married in the ER, preferably when they have presentations.
Immediately better outcome. Yes.
One of the big points for me was that 6-week timeline. So before that, I thought the general gestalt usually wait for 3 months. There were the so-called Weber studies from Holland, which said you can actually just wait, and they're kind of the same. So this study actually changed practice back towards being a little bit more aggressive with surgery.
Right.
In your own residency in Alabama, did this study get mentioned, and did this change practice?
Yeah, I think especially within orthopedic literature, it's a fairly big thing, the sport trial. We're tested on it. It's on our boards. We're pretty strict with trying to do non-op care for about that 6-week time point for any disc herniation, whether that's lumbar or neck. And after that 6-week time points, when we start having that surgical discussion with the patient, especially if their symptoms are worsening. And so I think the time frame is important. Again, with sport, they showed at 3 months that they had significantly better outcomes with surgery, but I think it does depend on what patient you're picking.
So Dr. Ziegler had to leave us. Rick, patient preference is a huge deal. And I think you alluded to that. Rick, are you still live?
Yes, I'm still here, Jens.
Great, super. So you hinted at that before, and we were a participant site in some of the disc trials. Patients who wanted to participate in this trial usually wanted to have a disc replacement. And they knew that they had a 50-50 or at least some form of a good chance to get a disc replacement. And I personally witnessed fusion patients, despite very similar outcomes, being disappointed. How much does patient preference nowadays impact outcomes in your perspective and from all your research experience?
Well, Jens, it goes back to the psychological makeup of the patient. And as you know, for years and years, we've always had patients undergo preoperative behavioral medicine evaluation. And Andy Block, who recently retired, published extensively on this. So I think it's really, really important. And these are sort of the questions that, we go through when you talk to a patient. You can explain to them, and look, you should give it 6 weeks, but unless they have, severe neurologic deficit. And a lot of it has to do with just spending time and talking to the patient and getting to know those patients. And, although some patients come in, they say, well, I want to have surgery right away. Why not? And I don't try to talk them out of surgery, but I explain to them why it's prudent that if they give themselves a little bit of time, their symptoms may well subside, just like we heard from, a lot of the previous studies. So it is really important, but I think that you as a surgeon have to manage it. And just because the patient asks for surgery doesn't mean that's the right decision.
Did you at TBI install a wedding chapel, like one of those Las Vegas drive-through wedding chapels for patients to improve outcomes?
Yes, we have one. We have one right in the center of the lobby. So, that way we give the patient a higher chance of success.
So Dan, give us, thank you. Dan, give us an epidemiologist's perspective. So there are some patients that clearly don't seem to do that well as others. Like Jim just pointed out some of those patients. When you're larger, you have claims going on, you're on opioids, you're unemployed, you're lower socioeconomic status or educational status. How does this influence our decision-making in terms of designing trials in the future when we have patient populations that clearly are more vulnerable towards sub-satisfactory outcomes?
Well, that's a good question. So, there's one way you can do it, just limit the criteria of those who are eligible, right? You can exclude those, but then that's less pragmatic. If you randomize, that's going to be equally distributed. As Dr. DeTore talked about yesterday, he didn't even want a patient who was obese to go into a certain arm because he knew the outcome would be bad. And so I would just suggest that we not think of it that way unless we know that there are real contraindications for certain groups. They should be excluded. Otherwise, include everyone, whether it's a randomized trial or an observational study. And then we just need to be very careful about how we control for those things. There are a lot of great comments made today as far as we cannot throw the sport trial out. Some of these sub-analyses can be very, very valuable. And so I think moving forward, we just need to be more creative about options. You can have a preference cohort and you can have a randomized cohort. You might even think about having a center that specializes in non-op care, taking care of the non-operative arm, and those that are specialized in doing the surgeries, taking care of the surgical. side of it. So you don't have these issues of surgeon factors and so on. But again, those patients need to be willing, because if they're randomized to a group that they don't like, to the prior comments, there is some demoralization that we see in the literature. So, you know, it's a difficult one, but I think we need to include them unless they are truly contraindicated, and then just do our best to control for the differences.
Great. So Dr. Geyer, take us out from here. Closing review. We thought that reviewing sport was important for our fellows and trainees to reflect on and to have in their knowledge base, because it did contribute foundationally to our knowledge base in many ways. But give us your big picture perspective. What have we learned? How has it affected our practice surgery, and how has it affected research going on from here?
Well, I think, you know, this is a landmark study that we have to know, and have to know it inside and out. But it also had set the stage for future studies and the way we look at scientific studies and the way we design them and carry them out. So from that standpoint, you always learn from history. And as long as we go forward, and now we have different outcomes, and as you alluded to earlier, we can't change things, but also we do surgery very differently than when the study was done. For example, the way we do fusion. So, but it's still from the historical standpoint, it sets the stage of how we can do better studies in the future. As Izzy talked about, how we can accumulate data with you know, all the different ways of predictive analytics that they've done a really good job in scoliosis surgery. We need to apply for these different types of entities as well. But again, it takes us collecting data, and I've always been a proponent of registries, although they have their issues. But in the future, we're going to do better and better studies, and we already are. So I think the future's bright. I think we're going to learn a lot more as we go forward. And hopefully we take a lot of the subjectivity out of our surgical decision-making and base it more on scientific basis. So I thought everybody did a great job, and I always enjoy hearing about the sport. I always learn something, and I think everybody did a great job. So have a great weekend, and thank you, Jens, and all the folks from Seattle Science, and Dan, and everybody else that participated.
Great to see you all, and thank you for your valuable comments and participation. And thank you, Dan, and everybody stay
Thank
safe.
you.
And thank you to our speakers.
All right, take care. Have a good weekend, everybody.
Take care, everybody.
And to you.
good.
Bye.